Uh, Good morning. Good morning. So once again, we welcome you all for the second day of ACSST Endoscopic Spine Surgery Cadaveric Workshop. So yesterday was a hectic day. I think all of you have enjoyed your evening. So today we will be starting with the lectures. So our guest faculty, Dr. Vijay Parihar, is there. He is a HOD head of the Department of Neurosurgery in Jabalpur Hospital. So sir will be talking about endoscopic discectomy using EasyGo and Distendo system. Before that, I will be talking about the endoscopic surgical anatomy of cervical spine, and Dr. Rahul will be talking about cervical and dorsal endoscopic decompression and complication avoidance in endoscopic spine surgery. And this will be followed by hands-on exercise or cadaveric demonstration. So I think we are all beginners level. So I want a house opinion whether we can go for the same lumbar level, or we can go for the cervical level. You want the demo of the cervical level, or you want to continue your exercise after the lecture on the lumbar spine? So how many of you want cervical to be shown?
Without knowing very nicely lumbar. And I think that is my personal thing. Although officially we had kept this day to demo the cervical, some part, and then go for. But I don't want to waste time. I think all of you should practice lumbar. So if anybody wants to see demo, then let us know. Otherwise, immediately after these 3-4 talks, we will go to the cadaveric dissection hall and start doing the lumbar again, practicing upon it. You want demo, so one person? All? Anybody else? You too.
Demo should be hands-on on there only, because it will take consume some time, 2-3 hours, and we are just watching and nothing practicing by our own. So simultaneously, the cervical and interested
Can watch the demo while others do the lumbar. Is that what you're saying? Uh, that is possible.
So, but everybody wants to demo, so that would be very cumbersome on a single table.
on that YouTube channel, you can watch.
No. This cadaver demo will be cadaver activity will be not on YouTube channel.
Can,
So cadaver will be not on YouTube channel, but that one we can do it. See those sometimes it's very philosophical. I mean, operating on the lumbar spine, as we say that having hands-on, going at level, going to level, even going from that to dorsal level and doing over the top decompression, because at dorsal level we don't go for the disc, we go over the top decompression. It is more or less similar to lumbar, but then everybody can do another level at the dorsal. And when we mark at dorsal level, we are already there to guide you there, right? That is one thing. Second, cervical. So as we move, yesterday also some people have damaged dura, and then you have difficulty, you were poking inside. These things cannot happen at dorsal and cervical level. Cervical level, the instrumentation become more critical, because in cervical you just do the over the top decompression, and when we operate on the opposite side, we have to use the conical burrs. You cannot be that rough that कि चलो हम ऐसे ड्रिल मार रहे हैं वो मार रहे हैं तो आपका चिथड़े उड़ जाएंगे ड्यूरा के और उसके अंदर. So it can be, I mean, you may be utilizing things, but you may be learning some wrong technique. What we can do, Dr. Park had operated very nice cervical ULBD case, right? And then we can share that link. We already, it is there, like operative link is already on the net. We can share, and we have continuous commentary into that, which will show that how to mark, where to go, and how to go on the opposite side. That will be easy. And if time permits, in one of the case, we can at the end, like when you are satisfied, one of the table, after lunch, on one table, we can start that cervical demo something, and those interested candidate can do it. But then it will be at the cost of something, right? I mean, they will be missing that part, leaving that table to the rest of the delegate, and you can watch that. But hands-on doing by you is not possible because it requires a lot of logistics, and it's not practically possible at this level of expertise, right? Yeah, that's.
Share the link, and afternoon, if people want, they can.
I just want to say one thing to you guys is that, for most of you, this is probably the first or the second workshop that you're attending. Don't chase cervical. It is not something to be chased. I saw most of you yesterday, we are even struggling for triangulation right now. Focus on lumbar. See, I did my first cervical spine ULBD after doing 200 lumbar spine surgeries. So it has a very steep learning curve. Although the organizers had kept it in a program, that's a very wonderful thought at their end. But looking at you people yesterday, trust me, focus on lumbar, because what I personally would want is that all those who have come for this program today, when you go back, at least 50% of you are able to start UB. If we focus on the whole varieties of UB, the spectrum of UB, it will not end, and you will not gain anything out of this workshop. And again, you will be like, I cannot start. So you will be again waiting for another workshop to happen. And this vicious cycle will continue.
Yeah. And one of the more important points, see, this is workshop is not a commercial one. If you believe that the logistic that you have paid 20,000 rupees, we might have spent 25,000 rupees just to maintain the logistic per person. Forget about it, because we wanted to be economical and we utilize all our help to do it. Otherwise, you just book today Indian workshop on UB and you will find the price tag, right? For one day. We are talking about 2 days. So we kept comprehensively depending upon the delegate rather than segregating them into advanced and things. So we kept that if possible, and if we are level, then we can do that. Another important point, what we have kept, the transition. Initially, you should be expert into the triangulation and over the top decompression and discectomy, lumbar. When you are expert with 30 to 50 cases, then only you should go for UB fusion, right? Then you go for dorsal, then you go for cervical. Dr. Park, so much expert, he was he was also in, no, I want all logistic before I touch cervical. I know the anxiety, right? So I mean to say, we will provide all the material from dorsal to cervical to the link to everything. And another important point, like as said, that this is just an open surgery. We have incisions, and through that same incision, we can show you. That's why Dr. Parihar is there. He has, I will tell you, he has trained generations of the neurosurgeons in endoscopy through his and Dr. Yadav's neuroendoscopy fellowship program over last 2 decades. He has vast experience of EasyGo and how the tubular you put and see the similar thing out, right? So if at all you have tubular system and you are started with the UBE, you are struggling, you can just convert into the open or tubular endoscopic system and can have an approach. So we have kept one EasyGo system on every table today also, so that through the same incision when you have worked, you can put that same dilator, EasyGo system, and can have a look like how these things are visible. So we have given a practical application there rather than imagining कि यार tubular से कैसा दिखता रहेगा, endoscope से कैसा दिखता रहेगा और open से कैसा दिखता रहेगा. Similar आप open करके आप देखोगे तो open vision से दिख जाएगा. So the learning point from A to Z, it is there in front of you. If you focus on something and if extra you want, we are always available. We will take you there to dorsal and cervical on the station if time permits, right? Am I okay? Great.
Thank you, Dr. Datta. Now, before we begin, I want Dr. Deepak Agarwal sir to please welcome Dr. Vijay Parihar sir, who has come all the way from Jabalpur for this workshop on a short notice. Thank you, sir. Thank you. So, like yesterday, I talked about the endoscopic anatomy of the cervical spine. Today, I will be lumbar spine. Today, I will be talking about the endoscopic anatomy of the cervical spine. So, the talk is only for the endoscopic approaches of the cervical spine. It is not a comprehensive talk. So, in 1946, Professor Scoville has started that posterior cervical foramen anatomy, and it has progressively evolved from open surgery to the tubular surgery, then to the endoscopic surgery, and then finally we are in an era of biportal endoscopic surgery. So I will be talking about biportal endoscopy and posterior cervical foramen anatomy, and its some advancements. So basically, what we do, we dock or we open the C5 C6 foramina, that is between the C5 C6 lateral mass, and we remove some bone. We remove the ligamentum flavum, and then we trace the root, axilla of the root, remove the disc or any bony compression there, and then the surgery is done. So, but for these procedures, there are limited indications. So, like Dr. Rahul said, Dr. Dattara said, once we are well versed with the lumbar anatomy and the lumbar UB procedure, then we can proceed for the cervical. And it have a limited indication. Its main indications are the lateral disc herniation, so located lateral to the edge of the spinal cord, or some patient which has ACDF and there is still some compression, we can go from the posterior side, or patient with a symptomatic unilateral radiculopathy caused by spondylitic foraminal stenosis. And it is not recommended for the patient with a central disc herniation, for the patient who have cervical spondylitic myelopathy, or the patient with a calcified herniated disc. So this is all it is not recommended. Although with time the indications are gradually evolving. So first of all, the journey started with the tubular retractors, then it goes to uniportal. Now we are in the era of biportal. So biportal was started in 2016, and the goal was the direct decompression of the neural elements. And the main difference between the biportal and the uniportal system is that the surgeon can freely and more comfortably mobilize the surgical instruments. So I will be talking about biportal endoscopic posterior cervical foramen anatomy, and a new thing like biportal endoscopic posterior inclinatory cervical foramen anatomy. So yesterday we have seen the anatomy of the lumbar spine. Now in the cervical spine there are lateral masses, and this is the facet joint. This is the spinous process, inferior articular process, and superior articular process. This is all same, but the main difference between the lumbar and the cervical spine is the nerve root. If we operate between the C5 and C6, the exiting nerve root would be C6. So this is, if in the lumbar spine, below the L4 will be the L4 exiting nerve root, and the L5 would be the traversing nerve root. But it is one level up. So if we operate between C5 and C6, the C6 would be the exiting nerve root. So if we have a cervical C6 symptoms, we have to operate between C5 and C6. So the concept of that biportal or uniportal or foramen anatomy depends upon the localization. The localization here depends upon the V point. What is the V point? V point is the inferior margin of the cephalic lamina. That is the inferior margin of the cephalic lamina and the superior margin of the caudal lamina, and where they meet, and the medial junction of the inferior and superior facet. That is a V point where we dock. And after docking, we remove about 3 to 4 mm of the bone, so that we can have a wider foraminotomy and we can decompress the neural elements. So our, I think biportal endoscopic port is around 4 mm. So we can go one up and one down, so to cover that level. So like yesterday we have discussed, we will be having one working portal and one endoscopic portal, working portal and one endoscopic portal. The same, the triangulation principles apply here. So yesterday, if you are able to do triangulation in lumbar spine, you will be able to do triangulation in the cervical spine. So same, that endoscope portal, which we put the endoscope through it, and the working portal through which the instruments goes. So if the patient is symptomatic on the right side, we will operate from the this side, and if the patient is symptomatic from this side, we will operate from this side. And the same docking principle, and the V point is our target point on X-rays. Now, so what amount of the bone has to be removed? This we have to remove that this bone and this bone. But the one important thing very necessary to understand in this lumbar spine, lumbar roots goes along the pedicle, but in cervical spine the roots goes above the pedicle. So this is a very important concept. The roots goes above the pedicle. So in order to free the pedicle, we have to drill the some amount of pedicle. So that there comes the concept of cervical pedulectomy, so that we can decompress the nerve root. Actually, in cervical spine, if we more retract the nerve, there are chances of traction to the cervical spine, and there are chances of injury. So to avoid that, we have to do some amount of pedicle resection also. So in superior articular this and inferior articular pressure, and some amount of the pedicle has to be removed. It depends upon the pathology, but many a times we have to do medial pediculectomy. And in most of the time, the cervical spine, the disc is between the axilla. You will never find a root shoulder disc in the cervical spine. So most of the time it is in the axilla. So if you try to put more traction on the axilla, there are chances of the traction injuries and cervical spine injuries. So you have to do some part, so remove some part of pedicle, and that is also helpful in the anatomical orientation also. So this is a classification given by Tanaka, in which there is a relationship between the pedicle, the disc, and the nerve root. So when the disc is proximal to the nerve root, and when the disc is located anteriorly to the nerve root, and the C, this is the most common type which we see, that is below the nerve root, and it is free from the nerve root. So like I have said, in the lumbar spine, the most important concept of the pars interarticularis. If we remove the pars interarticularis, there are chances of instability and there are chances of stress fracture. Similarly, in cervical spine, the facet removal is of vital step. If we remove more than 55% of the facet, there are chances of facetal instability, and then we have to fix it. So how much facet can be removed? It has to be 50%, less than 50% has to be removed. So in when you see post-op scans of cervical foraminotomy, you will see only this portion of the bone has to be removed. This has to be preserved. Otherwise, it will lead to instability. Now, when we do the posterior cervical foraminotomy standing on the one side, so we tend to drill more of the facet joint. On the same side, when we're drilling, we tend to drill more of the facet joint. So there is a concept given by Chang in around 2011. So he said, instead of doing dorsal foraminotomy, we can do posterior cervical inclinatory foraminotomy. So what was the concept? When this is the facet joint, if we drill in this direction, there are chances of more chances of facetal disruption, or more chances of facetal injury. But if we drill from this direction on angled inclinatory angle, so there are less chances of facetal injury, and we can save the facet more. So that is the only terminology That is what is PCIF is posterior cervical inclinatory foraminectomy. We do foraminectomy from an inclined angle rather than doing a dorsal. So this is like that. In traditional, we will do this, and when inclinatory foraminectomy, we will be inclining towards this. So generally, in inclinatory foraminectomy, the surgeon stands on the opposite side of the foraminectomy. We will go from the opposite side, and generally we use a 30-degree endoscope for better visualization, but it can be done with 0 degree. So V point is reached in mediolateral and inclinatory from different from the posterior paramedian approach, which addresses dorsally. So it is inclinatory, and what are the advantages? The advantages is that there is more preservation of the facet joint, and it is less damage to the muscle. In the literature it says, and we can allow a longer decompression of the exiting nerve root. So the take home message is that before selecting the cervical posterior foraminectomy, proper patient selection is vitally important. And we should have enough experience with microsurgical spinous procedures before biportal endoscopy, or you should go for tubular, then you can go for endoscopic, and identify the viewpoint for the starting point, and preserve the ligamentum flavum as possible until the bony decompression ends. And since the nerve root passes above the pedicle, and you have to retract the nerve root if we do not do a medial pediculectomy. So you have to be well versed with this procedure to avoid any traction on the cervical spine, and try to preserve at least 50% of the facet joint. Thank you for your kind attention. And this is that what we say posterior cervical foraminectomy. And if we stand on this side and do on the opposite side, it is inclinatory foraminectomy. Thank you. Any questions? We cannot in cervical spine. It's so it's like in cervical spine, the disc fragment is very small. It's like a pimple, as I have heard in some talks. So you cannot remove the disc. You have to just remove the protruding part.
So the cervical disc is very tight, right? I mean, Dr. Parihar has experience of doing anterior disc preserving a posterior discectomy. I mean, they commonly do it, right? Similarly, so the concept of disc preserving anterior discectomy, ACDF means like discectomy with one level fusion plating, that is for anterior. For posterior, acute disc with foraminal protrusion of the fragment, when you do the open foraminectomy with minimal approach, or you can use the zygo system with a smaller tube in the cervical, or you can use, even people have used the destin tube earlier, and now you can use the UV. But the concepts are similar as he has shown in his picture. You go to the V point, do laminotomy, take a small resection of the facet, you find out the root. Root is just in that, beneath that V point. And at that point, that protruding fragment of small root without doing retraction of nerve root, because you can't imagine, you can't retract C5, C6, C7 and your hand is gone. Better you do a big anterior surgery if you are not expert, right? So you find out by doing gentle bone drilling that area where disc is protruding, and you slightly create a space, and then you remove that fragment. That's what you have to do, nothing else. It is a fragmentectomy or sequestrectomy, right? Second indication that we had operated last time is for 2-level or 3-level compression. Sometime with UV, you are doing over the top decompression. The case that we did, and that what many people have shown now, I mean, they started extending the indications over the lumbar. These are all extension of indications. So when there is a anterior compression, lordosis is maintained, right? And you have done the over the top decompression, right? So you have started from one place. As we do laminectomy, so they have done a one side laminotomy and over the top decompression to reach opposite side of foramina. But still you don't handle the cord, you don't handle the roots, you don't, at that time you don't go for the disc and you remove the disc. It is indirect decompression from the outside. That's it. But still, like, many things can happen. I mean, if you don't maintain the alignment and if you only do the 2-level, that cord can get bowstringing through the anterior compression and posterior compression. So you have to select your cases very well. You cannot just put it like चलो अभी cervical में endoscope से चालू करता हूँ. Not at all. Very limited indication. So any comment on that?
I will just tell this during my talk. You
Yeah,
did it.
perfect.
Sir, Rajesh sir has given a very wonderful explanation about PCF and PCF, and what you told right now, that case selection is very important. Like cervical spine is still what we can say is under a trial modality of UB for even for dorsal spine. If you ask me, I can boast and say that my results for lumbar spine by biportal are equivalent to the results that somebody will give through a micro discectomy or through a distando. But for cervical, even the experts today, they still believe that the case should be very thoroughly selected. It should be a lateral disc herniation, that is lateral to the edge of the dura, and some small osteophytes can also be dealt if they are lateral. Any central herniation still requires an anterior approach. So cervical endoscopy has a very limited spectrum right now. The conventional dictum was about posteriorly discectomies cannot be done because, of course, we understood the anatomy right now. The cervical roots, they go out straight in this way. There is no shoulder. There is no shoulder. There is no concept of shoulder when we talk about a cervical root. There is only axilla. And the axilla can only be exposed if you've done a medial pediculectomy. You have to perform a medial pediculectomy unless, because if you don't do it, you will not see the axilla, you will not see the root over there. And posterior approaches were restricted to a multi-level degenerative spine where you will do lateral mass fixation, or you do multi-level laminoforaminotomies. But with advancements in optics, things have changed. People were doing a microscopic PCF, then they shifted to a Destandu assisted PCF and a PCIF. Now, with the availability of biportal endoscopy, people are now doing a UB PCF, PCIF. And between the two, PCIF is the most challenging. It is the most taxing on the surgeon because it has a very steeper learning curve. PCF is still easy because for PCF, even if you don't land directly on the V point, you can use the standard markings for a lumbar spine, dock on the spinal laminar junction, strip off the tissue, go towards the joint V point, expose it, and then take care of it. Now, when do you avoid the endoscopic PCF? Tumors, deformity, instability, infections, central disc, fractures. This is the standard. Any of these, and you have to avoid. Kyphosis, it is a deformity where we do not do a posterior surgery. Now, this is the standard equipment that you require that we've discussed earlier yesterday. All patients are taken under general anesthesia, positioned under on the radiolucent bolsters, and the neck is kept flexed. I'll show you the image which will give you a better picture of to how the cervical spine is positioned. The main key point here is you have to align the disc space that is to be operated to be perpendicular to the floor. This is the main key point over here. So this is the position. So if you look at this position over here, the patient has been fixed to the table on a silicone head frame, radiolucent bolsters. The arms have been pulled down, and now the elevation, the inclination that has been provided over here is such that the disc space to be operated becomes perpendicular to the floor. Unless you do this, you will not be able to reach the exact location. Rest is the same. The standard set of skin markings, the midline, the medial pedicle line, the pedicles, cranial and caudal. Similarly, this is the triangulation. Nothing has changed. See, nothing has changed. The only thing that happens is the cervical lamina are very narrow. The moment you dock at the spinal laminar junction, just 3-4 millimeters of movement laterally and you are on the joint. Always and always confirm the docking on the lateral view before you move ahead. I'm not saying that it is always necessary in lumbar. In lumbar spine with certain experience, you can take care of things, but no, in cervical, always and always complete your docking and stripping of tissues, that is a triangulation, in a lateral view live fluoroscopy. So this is how it looks like. We've just gone inside and taken care of some of the tissue inside. In cervical, you won't have the typical son space. You will be dealing with some muscle inside always. So remember this, son space does not exist in cervical and dorsal spine. That is why they become a little more difficult also. So here you can see we are taking care of the tissue with an ablator and exposing the lamina. This is the lamina, and we'll see the caudal edge of the lamina where the flavum can be exposed, and from there the drilling can start. This is the spinal laminar junction over here. This is the edge of the lamina, and we have the flavum exposed here. So this is where we actually start the drilling process. Now this is the patient. There is a large herniation over here. This was an extrusion at C5, C6, and this was a photograph taken just after the removal. And this patient had a pre-existing weakness of shoulder abduction, which gradually improved 3 months after the surgery. Immediately post the surgery, even I was scared. The patient was like, "Sir, I have no improvement." I was like, "Wait, give it some time." With physiotherapy, he improved. Now, this is one of the surgeries where there was an acute disc herniation. If you look at this, this is an acute disc herniation and gives you the best results. Docking again under lateral fluoroscopy. This is the scope confirmation. This is a laminoforaminotomy that has been performed. We've kept a lot of flavum intact, and if you see that over here a pediculotomy has been done, I'll show it in this one. A pediculotomy has been done and the disc has been removed. See, this is the root. Can you appreciate the root over here? Yes. So if you can see, this is the area, this is the caudal pediculotomy which has been performed, and there are a lot of adhesions over here. See, this is the disc. Just as we were discussing right now, the disc in cervical spine posteriorly is like a pimple. It's actually like a pimple. It's a very small fragment that comes out. This is the lateral edge of the dura, and then again we take the Indian knife. We'll give a stab incision over here on the annulus, do an annulotomy, and finish our discectomy. You have to be very careful. In cervical spine, there is no scope of retraction of the dura or even the nerve root. No, you can't. Even your hook, when you use it, it has to be so soft. Like I prefer using the hook which comes in the Microneurosurgery set. It is better to use that over here. So once the annulotomy has been done, a discectomy has been performed, we simply take the plasma ablator inside, coagulate the part of the disc and perform an annuloplasty. Now, it is very important to understand these points. So as I said, triangulation under lateral view live fluoroscopy, good outflow is always required. Confirm level again after soft tissue dissection. Preserve flavum till complete bone work, as I said yesterday. Avoid RF near neural tissue, and do not, trust me, in cervical spine, do not worry to convert to open. There is no shame, because ultimately our single point goal should be to give the result to the patient. Surgeon's ego should never come in between the outcome for the patient. Thank you.
Thank you, sir. Very nice talk. And any questions from the audience? because it is a next level surgery.
Nee, trust me, if like a lot of people, if they still feel that cervical demonstration is required, it's not a problem. But you will lose your time.
It's not a problem. When we want to deliver, we can open whole age for you. But I mean, it depends on how much you can take, right? Similarly, you can open all foods of the evening, but I mean, you should digest it well, right? So when we lead our delegates and everybody well, and then we provide as per our. But we are so respectful to all of you, like we ask you so that you can get best help from us, from our teams. But I'm sure one of the table we are going to do this cervical. We'll show you the finding, and those interested delegates can join because we are all learning together. But main important point to keep and cover is when you are seeing a program tomorrow at certain places, you should not be aware of cervical is here. We are making you aware about what we can do to UB. UB say even we can do intradural tumor, not advocate. They also in the different to see the decompensation. Now when we do distractions and any number of things, somebody can just do keep with more data of irrigation can that may be sufficient. Now we are talking about sub-select cases. Few cases which can be managed anyway, we can do that, but it is not a thorough solution for all civilians, right? Similarly, we are giving you overview of everything. You should know that if your expertise rises, you can go to the dorsal, you can go to the cervical. So what lies in your PT for next 5 years learning? Is it okay? So this is the point to tell you that what lies there. It is not very easy. And as we are neurosurgeons, most of the people here, we have to be gentle as the nerves and for to cervical. I mean,
सर अब थोड़ा डराने का टाइम आ गया, थोड़ा सा डराया जाए, असलियत दिखाई जाए थोड़ी सी. सर बाहर ही घूम रहे, थोड़ा सा क्या है सर, असलियत दिखाई जाए दुनिया की. So complications. Now it is very important to understand the complications of any surgical procedure before you dive into it. ऐसा तो है नहीं कि माइक्रो डिसेक्टमी में ड्यूरल टीयर नहीं हुए, ड्यूरल टीयर होते रहे, ट्यूब डाला तो भी ड्यूरल टीयर हुए. But UB carries with itself a whole a completely different spectrum of complications. So what you need to understand is that anybody who says मेरे साथ complication नहीं होता, वो झूठ बोल रहा है, he is not operating. That's the basic thing that you need to understand. And there are certain complications that come with spine endoscopy which are very unique. We'll talk about them. So, but overall, when you shift to spine endoscopy, especially full spine endoscopy, that is UB, the complication rates have gone down. But what has gone up is the recurrence and the residual. But that is because of the number of people who have just dived into it in the initial phases. The complication rates are high. CSF leak is 0, infections are very less, and neural tissue injury up to 4%. This is the data from the PubMed studies. One can clearly see this. Now, recurrence is a very particular complication that you need to understand. Is it can happen to anyone, and there is no individual factor from the surgeon's end, because recurrence tends to recurrence is defined as appearance of the same symptoms at the same level after an arbitrary time period of about 3 to 6 weeks. So the patient related factors such as old age, trauma, morbid obesity, these are important when you talk about a recurrence. But residual is somewhat particular to the technique, because initially what happens is you are taking a lot of time doing the bone work and your bony decompression is not complete. You're not able to retract the lumbar dura completely. You're not able to expose the shoulder properly. So this happens, and residuals in the initial part will be there, especially for a central disc and a foraminal disc, because these are two discs which are not easy to do when you are taking up UB initially. Now, dural tears are notorious. They will happen, they can happen. And yesterday, when I was talking about Hoffman's ligament, I told you that most dural tears in endoscopy, they are not because of your instrument. The video I'm showing is definitely because of my instrument, but you need to understand what happens is when we try to pull out the flavum, and in chronic stenosis, the flavum has a very tight adhesion to the dural sac because of very strong Hoffman's ligaments, and that is what usually causes the tears. However, apart from this, giant discs, RF instrument injury, annulodome injury are also very common causes of dural tears. CSF leakage, so far I have never experienced in my cases, nor has it been documented. However, yes, in bigger surgeries like fusion where the fasciotomies are larger, one of my friends did tell me about a CSF leak he experienced and had to convert to open to a formal repair later on. So this is a 60-year-old female who underwent an L4, L5 biportal decompression. If you would have appreciated earlier, there was some RF injury also. If you see the dura over here, this is lacking the capillaries. This was during the initial phase of my practice. And again, now unfortunately I have taken a fold of dura along in my Carrison punch while removing the flavum also, and I did not realize it unless there was a dural tear. Now this is a large dural tear. I finished dissecting the flavum and then I had to convert to open because I was not very well versed with endoscopic repairs at that time. Now, biportal endoscopy carries with it a very high risk of neural injury if you have a failed triangulation. By a failed triangulation here, I mean to say if you are triangulating in the interlaminar space, you've crossed the interlaminar tissue, you've crossed the flavum, you've torn the dural tube, and then you do the chopstick dance. Gone. Patient lands up with permanent cauda equina, never going to recover. This is what I'm talking about. L5S1, one of my friends had come for training under me. L5S1 grade 1 listhesis. He docks over here and then goes inside. So as I always say, before you start stripping, take a lateral view. We took a lateral view. We recognized this. I corrected it. We finished the complete surgery. Fortunately, there was a tear in the ligamentum flavum. There was no dural injury. Patient went back comfortably. Now there are certain rare incidental complications that we need to talk about over here. Seizures, pleural effusion, subtle hematomas, instrument breakage, neural deficit unrelated to the level of surgery, psoas hematoma, peritoneal visceral injury and instability. So seizures, they will happen because of excessive pressure being reflected. But then again, most of the surgeries that we do are under general anesthesia. So why are we talking about seizures here? Because I know people who are doing UB under epidural also. So they have had cases, so this has been documented. Pleural effusion, I'll just show one of my cases himself. Subtle hematoma without a dural injury has again been reported by Koreans. Instrument breakage is common. Neural deficit unrelated to the level of surgery, I'll just show you a slide. Psoas hematoma and retroperitoneal fluid collection, these are common with para-UB. Now what happens when you're doing a para-UB, there's something called as a intertransverse ligament, which Meena sir had shown us yesterday in the anatomic slides. If you breach that ligament, your fluid starts to go anterior into the abdomen. Peritoneal visceral injury. Now I'm going to tell you about this, about one of the patients who came to the urologist in our hospital. She was operated elsewhere. She underwent a monoportal interlaminar approach elsewhere, and the patient presented with a complete injury of the ureter on the right side. Ultimately, that kidney had to be removed. There was no option of restoring the ureteric length, the kind of damage that happened. So, since that patient had undergone a L3, L4 discectomy somewhere else, so that is why I was taken into the loop. And instability will obviously happen, as we were discussing yesterday. Datta sir was also repeatedly telling every one of us during the workshop, do not drill the isthmus, do not drill the pars, because if you drill away the pars, you're going to create stress fractures and going to cause a lot of problems. Now, mechanism for seizure, we've spoken about. Pleural effusion, extremely rare. Postulated mechanisms are capillary action for absorption of fluid, irrigation fluid under pressure seeping through exposed venules and lymphatics, irrigation fluid seeping through the cancellous bone. Now, the risk factors are when you use a pressure pump using a very high irrigation pressure that is more than 30 millimeters of mercury, and prolonged duration of surgery. So, my own patient, very large central disc herniation at L4, L5, presented with impending cauda equina. She's a teacher. We took her up for surgery. I had a very good outflow. I had a very good facial incision. I had the fountain sign. But during the surgery itself, somewhere like 25 minutes into the surgery, the anesthetist tells me, Rahul, something is wrong. I was like, what happened? The patient's ventilation pressure is going up continuously. So somehow we finished the surgery, and this is her X-ray, immediate post-op X-ray. See the amount of fluid over here, both sides. Around 1200 ml this side, 800 ml this side. Now, why did this happen? Despite me doing the standard surgery at a column height being just above my head, that is 100 centimeters above the waist, no pressure pump. Why did this happen? This happened because one of the new floor technicians who had joined, I had asked him to give 2 puffs at one particular point of surgery. So he made it as a life's mission that throughout the surgery I have to do that, and unfortunately that got missed out. So because of that, the patient landed up with this kind of a picture. Fortunately, this was recognized. We were able to manage it. Now, can everyone see these 2 MRI images? Are these 2 images clear to everyone? In the back also? Can you clearly see these 2 images? So, this is from a very dear friend of mine. We discussed this in Raipur also. 25-year-old, non-diabetic, non-hypertensive, non-dyslipidemic, undergoes a 2-level fusion by biportal endoscopy, L4, L5, L5S1. Wakes up, complete loss of sensory motor function below D10. This is the post-op MRI. You can see there's signal change over here at the level of C5, C6. Can you appreciate the signal change? Apart from that, there's a long segment signal change from D10 to the conus. It's been like 4 months now. This was July. Patient has not recovered any movement yet, and this is not the first time that I have heard it from a friend of mine or somebody else. I have at least discussed 5 or 6 such cases so far as to what went wrong. There is no explanation, because before this could have happened, other water related complications should have happened. But then again, this is an evolving technique. There are certain complications which we still are not aware about. So that is why I said, UB, everybody wants to jump onto the train that has departed now, but we are still have not understood the complete physiological changes that happen when you're doing a UB. I won't name the surgeon from North India, operated upon a first year general surgery resident, complete loss of vision in one eye, partial loss of vision in the other eye after surgery. No explanation. Normally we would have expected retinal hemorrhage, but that didn't happen. Retinal hemorrhage is a documented complication of using excessive pressure, but that didn't happen. Now the matter is in court. Let's see what happens. There's no possible explanation over here. Thank you.
No, very nicely and elaborated lecture. I mean, when we were discussing yesterday, and every table we were making you aware with every stroke that what can go wrong and how you have to be delicate, gentle, and that's why we're there till 6 p.m. with you guys, right? To understand that every stroke matters, and it can have some complications which are preventable, and sometimes they are just out of your. Anybody has any questions related to complications or anything in general?
Sir, in case of residual disc or recurrent disc, you go for again UV or open surgery?
I've had 2 cases of residual where unfortunately, like the patient was in the hospital only. When the patient had another episode of severe symptoms, we did an MRI, realized that there is a residual. We went through the same ports and we were able to deliver all the fragments out, and we made sure this time that we won't have the incident again. And in both the patients, females, morbidly obese, L5S1, preoperatively very large disc heights, all the factors which would contribute to a recurrence. So I am calling this residual because the incident happened within the perioperative period, next 24 hours, 48 hours. So that is what it will happen. And I will show you an MRI once we are down in the cadaver workshop. It's on the mobile. It's through one of the students. He operated a very large central right paracentral disc 3 days back, and patient post-op woke up with severe pain, and he was hell-bent on saying that, sir, the fragment is still there. I told him, you first calm down, get a repeat MRI. The repeat MRI was completely clean. I told him this happens because you must have given a lot of traction on the root during discectomy, and he accepted it. She was given some steroids. Next day patient was completely settled. But when such things happen, should always keep in your mind that there is a residual fragment and do a cross-check MRI. Bleeding in UB is altogether a different Pandora's box. I have personally never experienced a bad episode of bleeding, touch wood, and by God's grace that's not happened to me. But yes, people tend to put in a drain. There are different modalities that people use. Like what I do is, when my surgical work is completed, with a scope inside, I first take a suction inside and then stop the water and suck out the remaining fluid. And then I see if there is any bleeding that is getting collected which is abnormal. So there are different ways of people handling it differently. No, the bleeding is going to be there inside. Whatever is coming is going to be inside from the working portal also. So the suction goes through the working port. And see, I'll tell you, we'll discuss this in later. Let's first finish Sir's talk and then go downstairs and we'll talk about a lot of different things also.
See, now we keep clarifying it. Dr. Rajesh has beautifully shown the anatomy. Anatomy, he has shown that where the vessels come and they will bleed from that point only. From endoscopic port, it is easier to see the working port than the endoscopy itself, right? And while coming back, you can check all. So, I mean, but one important thing for bleeding control is if you are doing 5-6 cases a day, what people do it, like we have seen abroad, like they just like do it, put a flow seal, put a drain, close it off, put a pressure thing. But in that case, you should not be leaving any spurter out, especially when operating there is a oozing, you do that. Otherwise, you put keep some time, do meticulous close this one hemostasis and come out. It should not be a big problem because more or less still it is open in front of you, right? Sure. So Raj.
Thank you, Dr. Datta and Dr. Rahul, sir. Now we will be going in a totally different world. So, Dr. Vijay Parihar, sir, will be talking about endoscopic discectomy using EasyGo and Distendo systems. Welcome, sir.
Completely different work in the same hall.
Thank you. Thank you, respected Deepak Agarwal sir, Dr. Datta, Dr. Dodamani, Dr. Meena, Rahul, my friends, and all dear delegates. I would like to thanks, and from next year I complete my 20-year post MCH and probably 15 year of endoscopic surgery experience under the guidance of Professor Yadav. And when we have started, probably these biportal and monoportal has not been evolved so much. So everybody was talking about the tubular endoscopy. So we'll discuss what we have been doing with the tubular endoscopy from lumbar disc to craniovertebral junction, and how you can learn the basic principle of these UB from this tubular endoscopy system. A lot has been discussed, I think, yesterday also with all the talks, that endoscopic spine treatment is now well accepted. Safety is also established in experience, and there are many remarkable benefits with minimal risk. And most important is seeing the growing enthusiasm amongst the young neurosurgeons make it very widely popular. But there is a definite learning curve exists to acquire this skill, and one has to understand this learning curve for its safe integration and assessment. Cochrane is still said that microdiscectomy is still the gold standard of treatment. Others have equally effective with some added advantage, but the evidence is less clear that these are the superior than the microdiscectomy. So we'll started with the open, and then we'll switch over to the microdiscectomy, and then we'll come to the tubes with the microscope, and then the tubes with the endoscope, and then comes the these least invasive technique, monoportal and biportal. Many classification has been exist. This is the AO classification you can see, and there are so many classification where they have been actually kept the UB as a endoscopic assisted, though the letter has been given to the AO by the UB forum that any surgery which has been performed under endoscopic guidance should be considered as an endoscopic surgery, not the endoscopic assisted surgery. So many nomenclatures has been given. I think Rahul sir has already been discussed. So these are the basically two types of approaches, and I'm going to discuss about these interlaminar tubular endoscopic approaches. As far as invasiveness is concerned, I think the least invasive is obviously these wet endoscopy, but microendoscopy is also being done with 1.5 to 2 centimeter incision. So basic difference between the channel endoscopy and tubular endoscopy is they are wet, and the channel endoscopy has got a specific instrument. This is important for the beginners, that these instrument breakage rate and maintenance cost is quite high. By the tubular endoscopy uses dry medium, and even can use the simple standard micro instrument. They are least invasive, channel endoscopy, but they have a very tight patient selection. You have to select it properly, and there has been a steep learning curve. So far, so they are using only for decompression, though the intradural surgery is being started. But the tubular endoscopy is quite versatile. One tube can be used in the various places, and it is easy to learn and also can be used in the tumors. But the long-term results will tell after the studies. So these are the some of the instruments, and these are the simple instrument with the tubular endoscopy. So there are many spinal endoscopic systems are available which are difficult and applied to handle. So endoscopic system should be versatile and it should be applied in most of the indication. This should be easy intraoperative handling. It should be a standard bimanual microsurgical technique, and it should avoid a prolonged learning curve and gives an easy surgical performance. Those who want to start the surgery can be very well versed with these. So these are the tube system, the stand-to system, then comes the matrix system with endoscope. Then there has been modification of these stand-to by Dr. Satnam Chabra, Endospine Plus. Then it comes the storage, the smart system, which is I think the primary concept of UB like a smart system. They have got two portal there, but they don't use the saline. And this is the EasyGo system, which use a tube and endoscope 30 degree, and then comes the monoportal and then the biportal. So EasyGo usually you know that there are graduated dilators, trocar and the 4 mm 25 degree scope, and there are others simple instruments. You can see this is the EasyGo setup. This is a small video of the dilatation of the. These are the sequential dilators of different sizes. Then there are 3 types of trocar is available. One can start with the larger and then gradually shift to the smaller. This is the scope mount. And this has been attached to the endoscopic holder. And here you can mount the scope and do the surgery. Another video of external dilatation. First you confirm, and then about 1.5 to 2 centimeters skin incision has to be given, and then the gradual dilatation is done. Then the appropriate size of the trocar has been inserted, attached to the holder, and this is the scope, and the surgery was done with the 2 hands technique. And then you can turn towards the caudal side if you want to do the 2-level surgery. So we have learned from our experience, like these tubes from lumbar to craniovertebral junction, started from simple cases to complex cases and different type of the pathology. Lumbar disc is simple and ideal to start, done in the prone position with this special localizer, and then we'll confirm the level. Just a finger breadth incision. And then again confirm, because it is a docking which is very important to confirm in AP and lateral view. And then you will see the soft tissue, then lamina, the laminar adhering, and the fenestration was done. Then the phlebectomy. And then you can see the theca, and the disc is out. And this is the decompressed root. This is one of the video. I'll run fast. This is the docking. The drilling of the L4 lamina was done. You can use the simple your microsurgical instrument. take out the disc. This is another with the smallest port. You can see a very small bony work has been done here to remove the disc. Lumbar disc, after learning the lumbar disc, started the lumbar stenosis, because in stenosis you have more than one factor: degenerated disc, facetal hypertrophy, ligamentum flavum hypertrophy, narrow canal. So careful patient selection is usually important. We'll do less than 2 level, and we'll assess the CT MRI for complete decompression, spinous process thickening, lamina angle and thickening, and the facet joint interlaminar window and ligamentum flavum, assessment of the ligamentum flavum. After doing the ipsilateral work, you can just turn your tube towards the contralateral side, 10 to 20 degree, and then you can start seeing the undersurface of the lamina and do your work, and then ultimately assess the completion of the decompression. This is one of the example of single level decompression. First complete the bone work before doing the flavectomy. Then drilling the base of the spinous process, and then decompressing the ipsilateral root. Some medial fastectomy to open the lateral recess is required. This is the ipsilateral root. Discectomy was done. Decompress ipsilateral loop, and this is the contralateral removal of the ligamentum flavum. Drilling of the opposite side facet. And you can see the opposite decompressed root. A good view of the decompressed thecal sac was done. This is another case. You can see the complete decompressed thecal sac. This is the bony work which is done. This is the multi-level, 2-level you can see. We have published the paper also. We'll do the the same tube has been used for the anterior cervical discectomy for disc preserving approach, in which cases the fusion is not required. You preserve most of the disc, and motion segment has been also been preserved. So there are indication for anterior disc preserving surgery, disco-osteophytic compression and corporeal disc like this. There has to be careful patient selection. If there is significant posterior compression, congenital canal stenosis, unstable spine, if disc is migrated cranially or caudally, more than half vertebral level, probably you will not able to do it. At previous operation of the same site and compression is more than 2 level. If there is dense OPLL, then it is difficult to do the anterior surgery through the endoscope. And if there is a significant reduced disc height causing the foramen stenosis, probably you require the, can I have a water? So surgery of disc preserving was done with the same principle of ACDF. You have to make a space between this esophagus trachea and the large vessels on the lateral side, and then you dock your endoscope, and then you create an inverted funnel After drilling the smaller part at the end, initial of the body, and then the larger drilling has been done at the posterior end to decompress the cecal sac. This is one of the example. C6, C7 disc. This is we are docking. And now this is, we are approaching to the central. So these two are the longusculi and opening the anterior longitudinal ligament. And the further drilling has been done at the posterior osteophytes. Sorry. And then opening the PLL and taking out the and further removal of PLL and assess the decompress the blunt dissector. And this was the area which we have been, rest of the disc has been preserved. These are the, thank you. These are the sagittal alignment. Though it has been reduced radiologically, but patient is asymptomatic. These are the two labeled discs. I think I'll fast forward. This is the lateral disc if you are not able to do from the posterior side like thick disco-osteophytic complex. Then you can go from the oncoforaminotomy, lateral most drilling. And this is the, so we have published the disc preserving paper also. And if you want to do the fusion, if at all required, one can do the fusion single label with the same tube. So just want to say that it is a versatile tube and does not require any specific more equipments, and one can learn the principle which can later be utilized in these biportal endoscopy. And these are the corpectomy, though I have not been done, but Professor Yadav, after gaining experience, he has been done these two level corpectomy, central and oblique corpectomy. Posterior cervical foraminotomy with the small port can also be done. As Dr. Rahul and Dr. Meena has told, you have to drill the cranial and caudal lamina and part of the facet. And this is the root. This is another, if you required multi-level decompression with the same tube, one can take out the ipsilateral lamina and then carefully drilling the opposite lamina with very fine Carrison punch. You can take out the this is 4 level, but it takes time. The same tube has been utilized for Chiari decompression also. First we use with the exoscope, take out the, then drilling the foramen magnum, and then we switch over to the endoscope. And then the partial splitting of the dura has been done. That is a different sort of debate whether it is required, but in this case it has worked. To step up, though I have not been done, but Professor Yadav has been done a transoral approach and fixation through the endoscope. This is just a video of him This is drilling of the odontoid. The anterior surgery for CVJ itself is a debatable, but if it required to do the anterior surgery, it can be done with the help of these tubes. And this is the fixation through the transcervical. If you're not able to do the transoral or some contraindication or afraid of infection, then one can go the transcervical approach to the CVJ. And one can perform the fixation. IDM can also be done, a short video. But less than 1 vertebral or 1.5 vertebral level, preferably the neurofibroma has been indicated. So we do have a complication, lot of complications, CSF leak, root injury, incomplete decompression, wrong label surgery, need to convert into open surgery, produces the unstable spine, bleeding, discitis. But gaining the learning come, we have been have less. So one can start with simple to complex cases, attend the model hands-on cadaveric dissection. And there are simple tips and tricks can be learned from the mentor or from the literature to avoid the complications. We are using Exoscope. Exoscope is a very good tool. If you have, then it gives you a lot of experience to learn these advanced techniques. So my last slide is that choose the best outcome for the patient depending upon the patient pathology, your training, skill and experience, and the technique amongst you, which you think produces the best outcome. Thank you.
Very nice talk, sir. Very, it's those who are going from the microscopic to the tubular retractor system. It's a very interesting talk by sir. Any questions from the delegates? Yeah.
Sir, in anterior endoscopic anterior cervical discectomy, you will dock with like in lumbar, or you will give a small incision, then stillate first, stillate, then serial dilator.
Docking like lumbar is difficult because there are esophagus and the trachea and large vessels. So the initial incision is same as like we do for the microscopic.
Yes.
We created the space, and then by the putting the right angle retractor gently, and then we'll put 2-3 dilators, or even if you directly dock the main tube there under vision.
Yes, sir. Yes, sir. Sir, in spinal tumor, endoscopic removal of spinal tumor, intradural tumor, you do dual suturing with same tube.
Yeah. That is the advantage of tube, because tube has a freedom of movement also. And for that tube, you have a single shaft needle holder which has got a long and which has got a single shaft, just like a endoscopic bipolar. So by that you can close the dura. It takes time, but you can close the dura and you push the knot with the help of knot pusher or by the ball probe. And so there are anasto clips are available, but they are costly, where you can directly clip the dura.
So
See, another important point is, please understand, like he tried to show you all type of the cases that can be done, but to master, I mean, on only single case, it has a series of another expertise needed for that. So, I mean, to answer your question regarding the IDM, when you are doing it the UBE with the water, then you require hemopatch, you require hemoclip, you require n number of gadgets that may be easily be available outside or can come under the insurance. But here you cannot spend 1 lakh rupees when patient is paying for 20,000 rupees, right? Or and 2 lakh of gadget just to secure your cases. When in open you are utilizing same instruments, same sutures, but then it requires your technicality, how to work in depth through small channel. They have devised a very nice technique like how to go inside with a single shaft, and then that can be mastered. But still, it is a advanced level of surgery. Similarly, with tube he has shown what we were showing since yesterday, or you must have seen in the conferences, UB or any uniportal, and then we are showing going on dorsal, we are going on CV junction, we are going on cervical. Same thing we are doing since ages. I mean, I still remember first workshop 2014, first was the cranial endoscopy, and then another was with Dr. Yadav sir on this, like easy go technique, understand you technique. So we are doing since that time, and this kind of workshop and papers are, it was in fashion that time. So we were focusing using then tubes with endoscopic tubes. Before that it was X tube, and then we were all over the world kind of step, like series of workshop like this were happening. Then suddenly uniportal came, and since last 2-3 years UB has taken a forefront. But that previous experience will help you, because if you have seen through his nicely detailed elaborated talk, that all anatomy is same what we are discussing since yesterday. There is a lamina, there is a ligamentum clavum, there is a nerve root, there is a thecal sac. It won't change. It's just like you have advanced instruments, and you can do with a better fashionable way, right? So this is main idea, to convert, I mean, put both these talks and things together.
Dr. Vijay, it was a nice talk overview. Only thing is that just a comment on, you told that anterior surgery of CVJ is gone over. No, it's not. So, I mean, it's
If it is required indication, that can
Really, he thought he is in Mumbai. So in Delhi, we do anterior surgery as well. Sometimes if you talk in front of girls, say that as this one. So it is not, we do it. So it is in selected subset of patients when it is needed, especially in recurrent one. I mean, you have done a posterior fixation and patient have this, people can go with the endoscopy, transoral or retropharyngeal, and you can still do it. So any other question? So today was a very nice talk. We have seen a complication. All this complication can happen with UB, can happen with the tubular. But what all you can do with the UB right now, people are doing with easy-go and descending system since long period of time. It is just that with upcoming things, you have new gadget. Like you say that RF goes there and then coagulate, you don't have to utilize the bipolar. Similarly, you have hooded drills. You have nice drill system, you have conical drills, you have diamonds which goes there and drill. So, and your endoscopic is tip is just near it. So it increases your, I mean, visibility and working ergonomics well. So I mean, you take advantage of this additional things, and then it is going to stay. But if at all you want to convert, then if you start with the like this kind of tubular or endoscopy, it's not a bad idea. It is the same anatomy, you are just making sure that your learning curve improves better, right? Dr. DS, sir, you have any comments?
Nay, I think this is an excellent addition to the talks, because sometimes you get fascinated and fixated by new techniques, and biportal is a new technique, but it has its own issues. It requires its own set of equipments. And we are facing the same problem here at AIIMS Trauma Center and at AIIMS, because equipment is not available that fast. Whereas, using standard tubular systems, which we already have, and most of you might be having it, it's much simpler to start doing and assessing the anatomy, doing the discectomy with that, so that when you go to biportal, it's much simpler. I think that is the way we ourselves at AIIMS, we sometimes miss out on doing tubular and just do the open, because it's easier on the time and resources. But we have to go through a process, tubular, then biportal. That is what my sense is. And I think it's an excellent topic.
Yeah. So, and I was quite lucky enough. I was working at all front, to be very frank, since last 10 years, like I mean, I'm working with him in neuroendoscopy fellowship programs, and every time I keep learning. And so this is things happening in front of me. So I trust from bottom of my heart that what lies there. So when somebody try to tell me this way or this way, I mean, I know everything available in front of me. I myself conducting courses on those fronts since 10 years. I'm in neuroendoscopy program since 2015. I remember my first day. And when it comes to transit from easygo and destendu to the UB, for me it was, I mean, it was nothing else. It is just like पहले ऊपर काम कर रहे थे, अभी अंडर वाटर you are just doing swimming. That's it, nothing else. Rest of the anatomy is similar, right? And with UV you won't find, like uniportal, I still tell you that it is a difficult. When I started doing destendu, it is not we are glorifying this one, but I mean, I tell you the difficulty. He will himself tell. Like when you are doing easygo, it is like open surgery. You are putting a tube, rest of the things you don't have to do, your both hand are free. But when it comes to the destendu, it is like salsa dance kind of. You cannot just do a rowdy kind of dance. I mean, you have another suction in your hand. With that suction, you are handling whole of the tubular system like you are doing with the monoportal. Right now, whole monoportal stand, that tower on your left hand, and then with your 3 fingers you are managing everything, and then you have working port. Similarly, it was a destendu when I was doing, when we didn't have any other system. So in destendu you have suction which goes through that one slot, whole destendu together. Then you have neuro retractor and one small working port, and then through that synchrony you operate. So when you have stable hand, you know how to operate. Then you can, when you get more freedom, you can do a better job. So to transfer to UV was very easier for me because I was doing destendu. Dr. Rohidas was coming that time, and Dr. Yadav was also doing destendu, and he stick to doing the easygo. So I mean, destendu was the advanced level, but if you are doing destendu, then it is more easier to convert to the UV. It is, you feel that, oh, I got free, kind of, my both hand got free kind of stuff. So your previous experience, though it is open microscopy, this kind of tubular thing is won't go waste. If you are expert or you have little experience to that, UV is just like a easy baby to take. So Rajesh, conclude. Yeah. So I mean, because most of my topics and things have been in the discussion are already covered in the talk, so I don't have anything extra to show off except the videos. Not necessary. For the destendu and system, we'll show you how it works on the table. easygo also will work along the table. सर वो डेलीगेट से ही सर्टिफिकेट
इनके हाथ से
हाँ हाँ आप सबके हाथ में सो ऑल फैकल्टी हाँ सर आप आ जाओ तीनों सो ऑल फैकल्टी प्लीज प्लीज कम हियर अच्छा जिन्होंने सर्टिफिकेट लेके रखे वो वापस दे दो फिर से दे देंगे आप I told them to keep certificate ready so that we have to give in the morning. They are already given to you. Sure. Yeah, collect. टी ब्रेक नहीं भैया फोटोग्राफर है ना रिकॉर्ड करो देखो देखो मेरे पास दिखाओ सर राजेश आ जाओ भाई रमेश आ जाओ विजय सर so I mean all of you did a wonderful thing. Sometimes we have to be little harsh and strict. We are not like that. So, I mean, when we are on job, we are very strict. After 5 p.m., we rock hard, right? So, I invite Dr. Satish Dere.
नहीं आप दो
Dr. Bishop Paul. संजीव कुमार, प्रवीण कुमार भी रेडी रहना. प्रवीण, विजय दहिया, Vijay is, I think, attending from Sabdarjung, right? Earlier attending since long time. By the time I know everybody. आनंद गुप्ता, ओह माय गॉड मैन, हाँ मतलब आपका मैच होना चाहिए, आप ही दे. रक्षित शेट्टी, आइए सामने. रक्षित शेट्टी सर. सचिन केजी, रमेश, हाँ रमेश दे देना. हाँ सचिन के. अब्दुल नाशिफ is here.
Abdul hasn't reached yet.
No problem. हाँ. हनुमान प्रसाद, I mean, he should be awarded with the most interactive person. Believe me, he truly really I mean, faculty from the KGMU, he truly deserves that. So this is not like movie, no. Your question hurts me, but I mean, it's good questions. I mean, you know, Divesh Singh, because that brings lot of much other areas into the discussion. Divesh. Now we are calling Anna here. Sunil Shetty. Raj.
Sir, आप दीजिए.
Naveen DS. Asif Iqbal. आइए सर, आप बीच में आइए. आनंद करकर, आनंद करकर, अरविंद के यार नहीं. अनुज छाबरा, दिलदीप सैनी, सर. अरे नहीं सर, आप एक इम्पोर्टेंट बाकी है भाई. बात जिंदा. प्रशांत शर्मा सर, आप. रविंद्र श्रीवास्तव. अरे आप ही क्या लेना. रति मैडम नहीं है, नहीं आई है. अच्छा आ रही है. अच्छा अच्छा. अरे वो मुझे इसके सामने दिखी. सौरभ सिंह, सौरभ सिंह नहीं है. दूलघनी नाश. चलो डन. किसी को नहीं मिला ऐसा तो नहीं है. तुम्हारा नाम क्या? कोई बात नहीं, आगे तुम्हें सर्टिफिकेट मैं देता हूँ. आ जाओ. अरे मैं देता हूँ मतलब सर, मैं कोई भी दे देता हूँ ऐसा. थैंक यू. हाँ 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 हाँ। अच्छा तुम लेके जाओगे उसको। हाँ चलो फोटोशॉप नहीं इसको फोटो को ले लिया अनु छबरा को फोटोशॉप ठीक है चलो सो विल ब्रेक फॉर द ब्रेकफास्ट
उसके बाद बता दो सबको अपने अपने
हाँ हाँ they all know again we have to go to the same station start working since what you are left yesterday ठीक है we have then meanwhile we'll set up EasyGo system we'll involve all you all on the front and then we'll move on to the thoracic and all other levels right so start doing it take enough time till afternoon and then once you are done we'll move forward